All right, good. It's good to have an introduction to the introduction, then any mistakes that are made technologically, I get. So it's a real pleasure to be here. Dr. Weiss allows the International Medicine Institute to invite a lecturer every year or 2 years for a Medical Gram Round series. And this year is a very important one, I think, because it's a individual that had his roots in the United States medicine through the Harrington Global Observership Program. I think his career is the type of career you want if you're seeking excellence. So he graduated from medical school in Fortaleza, then came to the United States through the Harrington program to do an observership, returned to do an interventional. I know. An interventional cardiology fellowship, then went to do a postdoc, and then after, in the postdoc, he went to one of the most prestigious centers in all of Europe for research, and in interventional cardiology. And after his PhD, he went ahead and started continuing to grow as an interventionalist, and then finally joined Boston Scientific. And so I'll let the more specific invitation go forward. But I think it's a really interesting thing to have a person start here. We have 80 people rotate every month through our observership program here. So we're constantly having doctors doing all kinds of different areas. And it's just to see, great to see the final product. So, Musamil?
Thank you. My name is Taimur. I'm one of the Jackson Memorial Hospital internal medicine chiefs. It's my honor to introduce today's speaker, Dr. Rafael Cavalcante. He serves as Boston Scientific's vice president, and prior to coming to BSc, he served as an interventional cardiologist at the University of Sao Paulo. Dr. Cavalcante received his medical degree from the Federal University of Ceará, Brazil. He also holds a PhD in coronary imaging from the University of Sao Paulo and a postdoctoral research fellowship at the Erasmus University Medical Center, Rotterdam, the Netherlands. At BSc, Dr. Cavalcante is chairman of BSc Global Investigator Sponsored Research Committee and a member of BSc Clinical Evidence Strategy Committee. He has authored and co-authored over 80 publications on coronary disease and structural heart topics in all the major global cardiology journals. Please give a round of applause for Dr. Cavalcante.
All right. Thank you, everyone, Dr. Rice, Dr. D, Dr. Shatsisis, for having me here. It's a great honor, and it feels like what I started in medical school all those years ago, back in 2001, when I came here to do the observership in the Harrington program, that it's coming full circle, and it's a great honor for me to be able to stand here and talk to you about one of the topics that is a passion of my life that I worked on throughout my career in different sides of it, from clinical practice, research, and industry. And like I said, in 2001, I was here as a student, learning and getting excited about potentially having an international experience. Due to family reasons, I ended up not doing my residency and fellowship in the US. I went back to my country. But as it turns out, our story with my family was to be abroad. And again, it's a great pleasure and a great honor to be able to talk to you about coronary intervention today. I'm not going to go through this again, but I have to disclose very clearly that I work for industry. I'm a full-time or part-time employee for Boston Scientific, and I'm still in practice in the cath lab part-time. And I also want to disclose that I will be discussing off-label use of certain technologies as part of my talk, and I have that disclosure on the slides. But I wanted to start from the very beginning in the history of interventional cardiology that will explain how we got here. As you know, the pandemic, the COVID pandemic had a great impact in healthcare worldwide. But there was a trend that was happening even before the pandemic, that after decades of reductions in the morbidity and mortality associated with cardiovascular disease, we started to see a creep up and an increase in the morbidity and mortality and the disability adjusted life years, as you can see here from the Global Burden of Disease research, that showed that we were getting worse again in terms of how we control risk factors and how we control the morbid mortality of cardiovascular disease. And this is mainly driven by an increase in the exposure to the common risk factors that are associated with non-communicable diseases, specifically cardiovascular disease. And as you can see, since the 1990s, ischemic heart disease is the leading cause of death. That was also true before the pandemic, continues to be true today, and it looks like it's going to continue to be true for the foreseeable future in the next couple of decades. There's some advancements in medical treatment with PCSK9, with GLP-1 agonists, but like we saw with statins, while these drugs will have an impact, it's not going to be sufficient to solve this global problem of the most common and lethal disease that we have. And that's why it's important. This is an extract from the first article ever published in the first edition of the New England Journal describing angina. And it highlights how common this problem was to like 100 years ago and continues to be a major area of focus. So again, I think that the idea here is to understand where we're going with coronary intervention. And for that, we need to understand where we came from. So in the early 20th century, this German physician who was a fellow at the time discovered or documented the first catheterization. And a couple of decades later, he won the Nobel Prize for the works in developing cardiac catheterization with two other physicians from the Bellevue Hospital at NYU in New York City. And upon receiving the Nobel Prize, one of the physicians, Dr. Cournot, said this very interesting phrase that the catheter was the key in the lock. And it actually was, because just a couple of years later, Dr. Sones at the Cleveland Clinic almost accidentally discovered or described coronary angiography, and that led the way to where we are today with the start of coronary intervention as developed by Dr. Andreas Grunzig, who was a German living in Switzerland that was then recruited to the United States to work at Emory University. And Dr. Grunzig developed this, this method described in a poster presentation at AHA back in 2000 or 1979 or something, here in Miami, right? And Dr. Grunzig would have probably won the Nobel Prize for his developments. I had the opportunity to talk to Dr. Bernard Meyer a couple of years ago, who was one of his first fellows in Zurich and then took over when he moved to the US. And he had been approached by the Nobel community to apply for the Nobel Prize. But as some of you know, they do not award Nobel Prizes for people that are dead. And unfortunately, Dr. Grunzig died in an airplane accident while living in the United States. But he left this legacy and created this medical specialty that is the passion of many of us. And what he did was he developed this method to treat coronary obstructions with a balloon catheter that became known as percutaneous transluminal coronary angioplasty. And that is considered the first era of coronary intervention. So Dr. Grunzig developed this, but he already described the limitations of this method, right? When you dilate the coronary vessel with a balloon, you create dissections, which is the mechanism by which angioplasty actually works. But at times, these dissections can evolve and can obstruct the vessel acutely. So many of these patients back in the day, and I was not in practice at the time, but my father was, and I remember hearing from him and from some of my mentors at the time how many times they had to rush to the OR with a patient that was in cardiac arrest due to a complication of angioplasty. So angioplasty led to dissection, to vessel recoil that could culminate with vessel closure. And it was also prone to develop restenosis over time. So it was a fantastic development at the time, but it was full of issues to be solved, which then brings us to the second era of coronary intervention, which was the development of coronary stents. So this is the very first publication of the very first case series of coronary stents that was published by Professor Sarais, who was my mentor in Rotterdam when I did my postdoc. And as you can see, the results were not very good. 20% stent thrombosis, 30% restenosis. But this was the very first experience with what was at the time self-expanding stents. These stents are still in use today for carotid disease, but for coronary disease, we moved on to balloon expandable stents. So this is the second era. And as you can see, Professor Sarais again published the first paper comparing balloon angioplasty, which was the standard of care at the time, with coronary stents. At that time, we didn't have dual antiplatelet therapy, aspirin, clopidogrel, prasugrel, ticagrelor like we have today. So putting a metal tube inside the coronary was very complicated. It required anticoagulation. Patients had a lot of bleeding complications, but it did show that it was better than stents in terms of the occurrence of major cardiovascular outcomes. Just one note that this stent was developed and invented by this Argentinian physician called Julio Palmas, who was then hired by Johnson & Johnson at the time to work with Richard Schatz to develop that stent. And Professor Eduardo Souza, who I had the pleasure to know very well, passed away a couple of years ago, was one of the pioneers, was the physician that implanted the first Palmas-Schatz stent globally at the Dante Pazanesi Institute in São Paulo. So with the Benestent trial and a couple of other trials that came out at the time, the practice shifted to stents, bare metal stents at the time, to become the standard of care and not balloon angioplasty for the reasons we just discussed. But then these stents were good, but as you could see in the previous slide, the event rates, even with stents, although better than with the plain old balloon angioplasty, the stents still had an event rate of almost 20% at the end of the first year, showing us that while there was an evolution of the technology from balloon to stents, they were still not optimal. And this led to the development, once again, by the group of Professor Sarais in Rotterdam, of the drug-eluting stents, which are the stents that we use today in everyday clinical practice. So the first stent was developed by Johnson & Johnson, which was a bare metal stent that was covered with a polymer that eluted an anti-proliferative agent used in cancer, used in transplant, called sirolimus. And this study, the first in human use of these devices, were studied in a case series of 30 patients, half enrolled in São Paulo in Brazil, and the other half in Rotterdam, and then led to this global large randomized trial called the Rafael trial, that was presented in 2002 at the European Society of Cardiology by Dr. Maurice, who at that time said that the problem of in-stent restenosis was solved because these stents had the 0% rate of stenosis, or at least that's what we thought was occurring at the time. But as it turns out, this was not the case. These stents not only had restenosis, albeit in a lower rate, but they also had problems with re-endothelialization of the stented segment of the vessel, leading to stent thrombosis. And then in 2006, at the ESC conference again, a study was published showing that DES was actually associated, or the first generation of DES was actually associated with bad outcomes. And again, this led to the development of newer generations of drug-eluting stents, which are the stents that we use today. But it's also true that even with the most modern stent platforms that we have in the market today, of any brand, these stents are not free of problems. And it actually happens that the accrual of events happens at the rate of 2% per year, even with the most modern stent technology. So more than a decade ago, many investigators, Professor Sarais included, started discussing what would be the next technology that would solve these problems. And for a period of time, we thought that this would be solved by the development of bioresorbable stents, or bioresorbable scaffolds, as we call them at the time. So a whole program with a technology developed by Abbott Vascular started under the leadership of Professor Sarais to develop this bioresorbable stent that would ideally solve the problem of the balloon angioplasty causing dissections and abrupt vessel closure by having a scaffold, but would solve the long-term problems of stents by reabsorbing and disappearing over time. So that became the focus of the research in coronary intervention worldwide. But unfortunately, it turned out that this technology, or at least this first generation of the bioresorbable scaffold, was associated with several problems, and it was not only non-inferior to stents, it was actually inferior to stents, because as it's being reabsorbed and disintegrating, it causes stent thrombosis. So this is a recent publication of the final 5 years of follow-up of the entire ABSORB program, which includes 4 large randomized trials worldwide, showing that ABSORB was not the solution, or at least that version of the technology was not the solution, because it was inferior to the current metal drug-eluting stents that we use in clinical practice. So if not bioresorbable scaffolds, what is the next step, and what is the solution for this? And that's when things start to come full circle, because remember, we started with balloon angioplasty as invented by the genius of Andreas Grunzig, and trying to solve the problems of that initial technology. We created other problems by introducing bare metal stents, and then by evolving to drug-eluting stents. And now it feels like we're coming back full circle, because now what we're studying is balloon angioplasty again, but this time with the same drug that we use in stents, eluting in the balloon so it can be delivered by the balloon without the need to leave a permanent metal implant behind that would cause all the problems that we just saw. So that is the topic of the talk that I want to discuss with you today. As part of leading a world-class research organization for industry, investing billions of dollars in clinical research, it's part of my job and that of my team and my colleagues to try and think ahead. What's going to be the future of coronary intervention? What do we need to start investing now that will be the future 10 years from now? How do we need to start generating the evidence that will support the evolution of this procedure and this technology and how we treat our patients worldwide? And that's where the drug-eluting balloons or drug-coated balloons come in, is they come in to close that circle that started with balloon angioplasty all those years ago. And the rationale for the potential benefits for this technology is that it avoids the permanent layer of metal stents. And theoretically, it allows the vessel to move normally, so it preserves the normal functioning endothelium and the vasomotion that we know is physiologically very important for the homeostasis of our heart function overall and our coronary function. It's also helpful when a stent is difficult to implant or is a problem, for example, in bifurcations, which is very common. At least a third of the PCIs that are done worldwide are for bifurcations. And when you have to put two stents, it's always complicated, and the risk that there will be a problem of restenosis is higher. So this allows you to avoid that potentially. And it may also allow for shorter durations of aggressive antithrombotic therapy in the form of dual antiplatelet therapy. So that forms the rationale to why DCBs are potentially attractive. But this is not new. This was actually being developed as the absorbed bioresorbable scaffold was also being developed. So this is the first description by Dr. Bruno Scheller from Germany, published in 2004, of a technology that was coating a balloon for angioplasty with an antiproliferative agent, in this case, paclitaxel. And as you can see in one of the panels, it's untreated, and you see a thick layer of neointima formation. Hopefully, you can appreciate here the stent struts. So these dots are stents, and this layer here of neointima is the restenosis that will ultimately re-obstruct the vessel. And in a panel like this, you see that the drug is able to inhibit the formation of the tissue and prevent restenosis from occurring. So that was the rationale. Today, we have a number of different balloons, mostly approved in Europe, but we have a number of Chinese technologies that are approved in China and other technologies that are approved in Latin America. And we were very late to bring this technology to the United States because, again, like I said, the first randomized clinical trial in humans was published in 2006, so almost 20 years ago. And only last year, we brought the first of these technologies to the US, and I'm going to touch on it a little bit in the next few slides. But the idea here is to test this technology initially for the treatment of in-stent restenosis. Why? Because in-stent restenosis is common, as you can see from the data here from the NCDR CAF-PCI registry, which is the registry governing all the PCIs performed in the United States, showing that 10% of PCIs in that registry are for the treatment of in-stent restenosis. So patients that are coming back to the lab after getting PCI with a stent with a reobstruction of the lesion. And on the right side, you can see how difficult it is to deal with this problem, because when you compare the treatment of in-stent restenosis compared to the treatment with native vessel disease, so the first angioplasty compared to the second angioplasty in the same patient, the outcomes are much worse when you're treating for the second time, which is not surprising. But what's I think very notable and interesting is that from 2005, 2006, when the first studies came out of drug-coated balloons for the treatment of in-stent restenosis, all those trials were small randomized trials with angiographic endpoints. They were not large trials with clinical endpoints that would be more definitive in terms of the quality of the evidence. Up until we were able to do the agent IDE trial, which is a large randomized trial that was done for the first time to compare balloon angioplasty versus drug-coated balloon angioplasty. So we're going to look a little bit into this trial in more detail. So this is a 600-patient randomized trial. It was a randomization 2-to-1. So a double number of patients got the test, drug-coated balloon, compared to the control arm. And the primary endpoint of target lesion failure, which is a composite of cardiac death, target vessel myocardial infarction, and target lesion revascularization, was reduced by 40% with the use of the drug-coated balloon. And this was very importantly driven by a 50% reduction in the rate of repeat PCI, or target lesion revascularization. But it was also associated with a 50% reduction in the rate of myocardial infarction, which is a very hard outcome that we definitely want to prevent because it is associated with mortality, as you know very well. We recently presented the 2-year data of this study, and as you can see, the curves on the right-hand side continue to evolve. These patients actually have multiple repeated events. When they have the first restenosis, the risk that they will come back with the second restenosis is very high. And as you can see, there's a very significant treatment effect of the drug-coated balloon compared to the uncoated balloon. And what is interesting is I showed you that the bioresorbable scaffold was associated with a very high rate of stent thrombosis, which is a catastrophic event because it's an acute occlusion of the stent with a mortality that reaches up to 40%. And here you can see that up to 2 years, there were no cases of stent thrombosis with this balloon, which is very encouraging for the safety of this technology. But there are, like I said, multiple different technologies that are similar. And this is a meta-analysis of the first 10 randomized trials. This was a patient-level meta-analysis, so they put all the 10 databases together and analyzed it as if it was one study. And as you can see, while the target lesion revascularization was numerically higher with drug-coated balloons compared to DS, or even reaching statistical significance, this was driven by the restenosis of drug-eluting stents, not bare metal stents. But this was also associated with the inherent bias that when you first treat a patient with a drug-coated balloon, there's no metal. In the control arm, you put a stent, there's already a metal. So if that patient comes back, the one that already has a metal, you're going to be more reluctant to put a second layer of metal because you're going to create a real estate problem because in a thin vessel, you already have 2 layers of metal. So that might explain why the results were numerically superior for DES. But when it comes to safety, it's actually reversed. So drug-coated balloons were numerically better than drug-eluting stents when it comes to hard outcomes like all-cause death, myocardial infarction, and thrombosis. So this is data that supports the safety and efficacy of this device for the treatment of in-stent restenosis. And on the basis of that 600-patient trial I just showed you, the FDA approved this device in the United States for the treatment of in-stent restenosis. So now we have this treatment here in the US like we've had in Europe for 15 years, like we've had in Latin America for the same amount of time, and also in Asia. But where the things start to get really interesting is when we start to ask the question whether these balloons are going to be effective not only for the treatment of in-stent restenosis, but for native disease, for de novo disease, which is 90% of the PCIs that we do on a day-to-day basis. So trials with different balloon technologies were done in the past, mostly in Europe and in Asia. This is one of them called Basket Small 2. that randomized patients with small vessel coronary disease. And what is that? These are vessels that are less than 3 millimeters in diameter, because we know that the results for stents in large vessels are good enough as they are today. And we still don't know about the safety and efficacy of drug-coated balloons in an all-comers type of population, in the patients that we usually treat with stents today. So this was the first trial that showed non-inferiority of a DCB compared to a stent for the treatment of de novo disease in small vessels. And more recently, this is, again, a patient-level meta-analysis of 3 trials that compared DS with different DCB formulations of different brands and different companies, showing that the DCB does actually better than the stents in the long term, 3 years of follow-up for the treatment of de novo disease. Conversely, this is a very large trial, the largest trial done so far. It's a Chinese trial that tested a Chinese technology that failed to show non-inferiority to stents. So in this Chinese trial, stents were better, but they were better only in large vessels that you see on the right-hand side, vessels 3 millimeters or more. In the small vessels, the balloons didn't, as well as the stents. So as you can tell, now there's conflicting evidence. So we still need to continue to investigate whether these DCBs are good. You have a large Chinese trial failing to show an excellent result for the DCB, but you have different meta-analyses showing that other balloons, other technologies from other companies may work. So is the field ready for a paradigm shift? I grew up hearing from my mentors that they were happy with stents because doing balloon angioplasty at the time was cumbersome and it was risky. But now we live in a different era. We live in an era where abrupt vessel closure doesn't happen anymore because we have dual antiplatelet therapy. We have more aggressive antithrombotic therapy. We have intravascular imaging, or intravascular ultrasound, optical coherence tomography to guide the procedures, to make the procedures safer and of better quality. So can we change the paradigm and come full circle, go back to balloon angioplasty, now using these new technologies that deliver drug? And if you think beyond that, can we deliver other types of drugs? Does it make sense that we can deliver drugs that will stabilize the plaque once and for all? So these are questions, and this was a very nice lecture by Dr. Juan Granada at TCT last year. He's one of the pioneers of the research in this field. And his conclusion is, yes, the field is ripe for that because we are more comfortable operating on these complex lesions. The technology has evolved significantly, and these balloons can provide benefit in a host of different indications. But again, especially in the United States, where we don't have an indication, this is still off-label, we have to study. And this slide here shows all the trials that are ongoing worldwide. We know that in Japan, about 30% of the angioplasties now are done with a drug-coated balloon. In China, it's probably more than that. In Europe, it's approaching 20%. And we're just starting the experience here in the US. So just a couple of weeks ago, we were able to get FDA approval for a clinical trial to study this. This is going to be the STENS trial with the Boston Scientific Technology, but you have a number of other trials with other companies like Cordis, Medtronic, and Concept Medical. There's at least 6 IDE US trials that are ongoing or about to start. So we're going to be bombarded with high-quality evidence of randomized trials that will once and for all answer the question on what is the real role for these drug-coated balloon technologies in modern PCI, in the way that we do coronary interventions in 2025. So what I would like for all of you to take home with from this very brief talk is that, first of all, we saw different studies showing different results. That tells us that there's no class effect for drug-coated balloons like we have for stents. Today, most stents, regardless of what brand you're using, they will yield the same results. That is not true for drug-coated balloons yet, because the coating technologies are different, the drugs are different, the doses of drugs are different. So we need to test all these balloons, and that's why all the companies are coming with these randomized trials to get approval for their technologies. But the use of DCB for restenosis is now finally approved in the US, and we're seeing a very rapid uptake of this technology across the country, and this is going to likely become the standard of care for the treatment of restenosis, as it has in Europe, as it has in Latin America and in Asia. What we don't know is how these devices perform in the scenario of de novo native coronary disease. There's a lot of evidence that's been generated in Europe and in Asia, but there's a lot of evidence coming in the US. So this is still investigational, and all the trials are on the way. And depending on the result of these trials, that's how we are going to understand if this is actually indeed the fourth era of coronary intervention, and if we have indeed come full circle back to how Andreas Grunzig devised coronary disease to be treated percutaneously, which is with a balloon to dilate the atherosclerotic plaque. So this is what I wanted to talk to you about today. When I think about this topic, I always think about this quote from Albert Einstein, that the distinction between past, present, and future is nothing but just a permanent illusion. Thank you for your attention. I'm ready to take questions, and it's an honor to talk to you.
Thank you, Dr. Kaufman. Welcome home again. That was a great talk. We appreciate it very much. While people are getting their thoughts together and their questions together, let me ask you one. Is a stenosis a stenosis? Is it true in a native coronary artery, let's say, are there certain patients who might be better suitable for a drug-coated balloon versus a stent? For example, diabetics that have, you know, classically different type of coronary artery lesions, or is any stenosis free game here, and how do we look at that?
Yeah, that's a critical question, and it will be answered by the clinical trials that we're conducting. But what we can say is that there are certain anatomical subsets and clinical subsets that are potentially more better treated with drug-coated balloons. Like you said, diabetics tend to have diffuse disease. So it's very difficult to treat them with a stent, because you can't not simply stent the entire coronary tree. You're just going to leave the patient with a very high risk that restenosis will occur somewhere. So the fact that you can do this with balloons just delivering drug to a long segment, it makes the diabetic patients and patients with long lesions or diffuse disease patients that are potentially special candidates for that. Bifurcations are another example, like I said. Small vessel, because if the vessel is thin, less than 3 millimeters in diameter, stents tend not to do very great, and then the risk of restenosis is higher. So that's where drug-coated balloons are potentially even more beneficial.
Any other questions? Well, I thank Dr. DiMarceno for sponsoring today's lecture. I thank our speaker for coming back home. And we look forward to inviting everyone up to the podium and asking your questions individually if you wish to. Thank you. I remind everybody that the QR